So this section is on 556. This is right under acute respiratory failure. All right. As already mentioned, the treatment for respiratory failure and ARDS are oxygen therapy, correct? Now, however, we accomplish that by any means, either cannula, simple mask, non-rebreather, BiPAP, and then finally through invasive means, okay, inserting an artificial airway. Because you cannot put someone on a ventilator without another artificial airway. So we have to insert an airway first. The most frequently used initial artificial airway is the endotracheal tube. So this is a plastic tube inserted through either through the nose or mouth. And then the tip lodges in the trachea. We prefer endotracheal rather than oral intubation rather than nasotracheal. Nasotracheal is just too traumatic. Plus, if you choose the tracheal, then that means you have to contend with a smaller airway because the nose is smaller, so that means your airway is smaller. So the mouth is the preferred route. So who gets intubated? So this will answer the questions on indications. So on your blueprint for next week, it says the indications for endotracheal intubation. So this will be one of the answers. So patient is in respiratory distress and cannot be treated with simpler methods or non-invasive means. Another who cannot maintain an airway. Patients who are comatose, because these patients, once their Glasgow Coma Scale is below 8, can they protect their airway?
No.
No, they're so unconscious that they are at high risk for aspiration and death. So also patients who have any airway obstruction, upper airway obstruction that is, or those who require surgery using general anesthesia. So those are some of the indications, okay? All right, so this is the setup. As you can see, it's a plastic tube. How did we insert this? Well, we need another instrument, which is the laryngoscope. So it's a metal device which will help us open the airway and then insert the tube. Now, it's not always successful because, as you can see, there are two tubes. The trachea is the target, which is the anterior tube, and then there's a epiglottis there that covers it. So when the patient swallows, meaning the patient is still semi-conscious and you insert this thing, once the patient swallows, then the tube ends up in the esophagus and not in the airway, not in the trachea. The standard procedure or protocol now is rapid sequence intubation. So let me just describe what it was during my time. So when I was going to school up to first couple years when I was working, we did not have rapid sequence intubation or what we call RSI now. What we had was we held the patient down. So there'll be 5, 6 of us holding the patient and then someone holding the head and then the intubator is on the top of the head. Okay, so most of us got kicked, punched. Okay, because this patient, no matter how hypoxic they are, and especially if they're hypoxic, they're confused, right? They don't know, they can't tell if you're helping them or not. All they know is they cannot breathe, and here are a gang of people holding them down. So of course they will fight. Okay, so it was not the easiest method, okay, or the safest method for both the patient and the caregivers. So now we have rapid sequence intubation. With the exception of patients who are in cardiac arrest, we don't need to sedate those patients because they're unconscious, okay? They're in cardiac arrest. But if they're not in cardiac arrest, we have to follow rapid sequence intubation. So what that means is within 20 to 30 seconds, the intubation is over. All we do to peacefully do that is give the patient a short-acting muscle paralyzer, which is usually rocuronium or let's say succinylcholine, but in this, most facilities use rocuronium. Okay, so we inject that couple seconds, and then couple more seconds later, the patient is out like a light. Okay, so they are totally paralyzed, and then the drug has a short half-life, by the way, don't worry. So it will just paralyze the patient, so no fighting, okay, no injury to anybody, including the patient. So we can peacefully put the laryngoscope and then insert the endotracheal tube. Okay, so very peaceful, very fast. Again, 20 seconds, it's all done. Okay. So once the tube is in there, so we need, as you can see, if this is connected now to either a bag or the mechanical ventilator, when the breath is pushed into the patient's lungs, of course, the lungs will put up resistance, correct? So there are two organs there that put up resistance, the two lungs and, of course, the diaphragm, the breathing muscle, okay? So therefore, you will meet resistance when you push air in there, because that's not how we're supposed to breathe. How we breathe is the diaphragm contracts downward, air is sucked in from the atmosphere, correct? That's how we breathe. This time, the patient is not breathing. You have to force the air in. So of course, that will meet resistance from the lungs and the diaphragm. If that's the case, air will leak around the tube, correct? Because look at that, the tube is smaller than the trachea, correct? So of course, when you force air in, once resistance is met, some of that air will come back out, leak around the edges, the sides of the tube, and then back through the mouth. Now, to maximize therapy, we don't want any leaking. So we will have to inflate that cuff. So this is the cuff, okay, this section here. This is a cuff, kind of like a Foley. Okay, so this, like, imagine like this is a solid Foley. Okay, so we put it in there. Of course, this one will be delivering breaths, correct? This is an artificial airway. So we will have to inflate that cuff just enough to seal the airway. Now, we don't want to overinflate it because the trachea is living tissue, correct? So if you overinflate the cuff, will it cause ischemia by pressing against the vessels around the trachea? And that will cause tissue necrosis, right? So you'll have tracheal necrosis. However, we also don't want to underinflate it because if it's underinflated, correct, so leaking will occur. Plus, what will happen to the secretions? Secretions will go into the patient's lung and the patient will aspirate. So the cuff there, inflation, serves two purposes. One, it's to, actually, it does not anchor. I'll explain why later. So what are the two purposes of inflating the cuff?
Prevent air from.
Prevents leaking and prevent aspiration. Okay, so it does not really anchor, unlike the Foley, which anchors the catheter in the bladder. This one doesn't anchor it because,
On the strap.
right, so what will anchor the tube are commercial straps around the tube, okay, outside the mouth, and it will strap around the head. Okay, so the cuff there does not anchor at all. It will just slide.
Oh, that's also
Okay.
easy to suffer.
Correct. So that's why the patient can pull this. So with nothing holding, patient will have no problem pulling this out. All right. Okay. Because in the first place, we did not overinflate it, because overinflating it will harm the tracheal wall. Okay. It will cause tissue necrosis. It will cause ischemia. Okay. So let's go to our responsibilities now. So again, 20 seconds, this thing is over. And we don't take part in the intubation procedure. Either the respiratory therapist or the physician does that part. So your job is to make sure the patient has an IV access, because otherwise we can't give the propofol or the rocuronium rather. So once the tube is in, this is now our job. So your job is make sure the patient has an IV access, right? We need that at least two. Okay, so we gave the drug to paralyze the patient. They inserted it, the tube, 20 seconds later, now we're done. So we start bagging the patient manually first. The ventilator should be there, but we do manual first, okay? Because we have to confirm placement first. The tube must be positioned 2 centimeters above the carina. So the carina is the point where it's your right and left mainstem bronchi form. Okay, so this part right here is the carina. Okay, so this is the trachea, right? Trachea, and then right mainstem bronchus, left mainstem bronchus. Okay, so that part there, that crotch, if you compare it to your legs, that would be the carina. So we want the tube to sit 2 centimeters above that, so less than an inch above. How do we know it's 2 centimeters above there? We need an x-ray. So right after this is intubated, we need a stat x-ray. Usually if it's a code, x-ray is already called. All right, so they should be on the floor already together with the team, meaning when you call a code, the x-ray technician is part of the code team. Okay, so they're there. And then security is there, supervisor, and there's teams in the residence. So the medical team is there, and then the ICU team will also be there, and then the ICU nurse will be there carrying the commonly used drugs. Okay, although they're in the cart, but they'll bring theirs as well. Okay, in case we need extra. Okay, so here's the inflation of the cuff. Now, inflation of the cuff will be with air. Okay, we don't inflate it with water or saline. Okay, just air. We inflate it again to prevent leaking and to prevent aspiration. Now, the statement used here is to minimize because honestly speaking, can we really prevent aspiration? Impossible. There will be aspiration. Okay, but we can minimize. Okay, so the x-ray will be taken. However, give it time because how long will the x-ray technician take from... No. They're already there, right? They take a picture. Although it's modern now, the x-ray machines do have digital now. So the doctor will look at it and see the position. Now we have confirmation. However, let's say you're in some rural hospital. We don't have that yet. So they have to wait until the x-ray tech goes down the hallway, down the elevator, develops the film, transcribes it, and calls on the floor. So that'll take at least 10 minutes, right? But now it's all digital. So the doctor will see, okay, it's 2 centimeters. Go ahead and anchor it, okay? Now, until then though, because there's 2 methods to confirm placement. One is x-ray, the other is through end-tidal CO2 level. End-tidal CO2 means you put a capnometer, just a small device at the tip of the ET tube, right here, that's exiting through the mouth, this part here. You put the sensor there and it will tell you the CO2 levels coming out of the airway. So if the CO2 level is normal or high, where's the airway? It's in the lung, it's in the trachea. If it's low, it must be in the stomach. There's no other place it would be, okay? Right. Other methods too, of course, we can tell where it is, right? I mean, when you give the air, what will happen to the chest? Yeah, so there will be chest rise, okay? Bilateral chest rise. What if only one side, only the right?
Oh, it's actually inside of one.
Okay, so the tube is too far down. And when you insert it too far, it always goes to the right. It can't go to the left because the left is, well, the angle of the left mainstem bronchus is sharp. So it can't, a plastic tube can't make a sharp turn. So it always goes to the right, which is straighter, okay? So if that's the case, you'll be given instructions by the radiologist, okay, pull it up, because there are numbers on the ET tube. So they'll give you instructions on, okay, pull it up to, let's say, number 55, okay? And either way, you'll be given instructions, okay, to make sure it's in the right place. Otherwise, you can also tell through lung sounds, okay? But there's really no replacement for the x-ray. This just means that, let's say you in that rural, godforsaken hospital, which takes 10 minutes to get an x-ray result. In the meantime, what are you gonna do for 10 minutes? The patient has to get breaths, right? You have to start the ventilator. So those are the other ways you can tell that, oh, it's in the right place, okay? Until we get the x-ray confirmation, okay? So you need what are the other ways again? End-tidal CO2, symmetrical chest rise, and lung sounds. Okay. What if the stomach inflates? Okay, so the tube is in the esophagus. All right, so now let's go to the cuff inflation now. So the intubator will inflate the cuff. Now we don't know how much to inflate it exactly. We can approximate, but there are methods to do this. The most commonly used method is it's not mentioned here, but it's called the minimal leak technique, MLT. What they do is listen to the neck, okay, to the trachea, with a stethoscope, and then they will, of course, if the cuff is flat, meaning it's not intubated, I mean, it's not inflated, will you hear leaking?
Yes.
Yes. So when we hear leaking, okay, so there's a leak, the cuff is flat, and then we will begin inflating the cuff slowly. Once there is no more leaking sounds heard, we stop inflating the cuff, meaning have we achieved minimal leak technique?
Yeah.
Yes. And the others do a minimal occluding volume, but most people use minimal leak technique, right? And then to make sure that there's really no overinflation or underinflation, we will use a manometer. I have no picture, so I'll show you a manometer. Okay, here it is.
CO2, symmetrical chest rise and what?
Lung sounds. Okay, so this is a manometer. This one, the blue screen. Okay, so it's like a tire gauge pressure indicator. So you attach this to the pilot balloon. Okay, so our ET tubes look like this. Okay, so you see these pictures? Okay, so that's the ET tube. If the cuff is inflated, the pilot balloon will also be inflated. Okay, so this is the pilot balloon. So you attach the manometer, this one, to the pilot balloon and then press the trigger. Now, here's the trigger. Okay, so you press the trigger and it will give you a pressure reading. The pressure must be between 20 and 25 millimeters of mercury or 24 and 30 centimeters of water. So memorize those numbers that will be on the exam. Okay. So these ranges are the safe ranges, meaning it must never be under 20, never over 25 millimeters of mercury, or never under 24, never over 35 centimeters of water. Are we clear? Underinflation causes what again? Leak and aspiration risk. And if it's too much,
Damage.
okay, tracheal bleeding, ischemia, or necrosis. All right, are we clear?
Yes.
All right. So why a range? Because we don't know how wide the circumference of each person's trachea is. It varies. Okay, so some people are tall, some people are short, and some people are heavy, some people are thin. But we know that these are the safe ranges for inflating a endotracheal or tracheostomy cuff. All right? Okay.
So if it's someone like heavier and they do that, and then they're still, when they do the test, they still leak, they
Mhm.
would inflate them.
Well, let's say we're already at 25, yeah? And then you still hear a leak, you have to have an order. So you ask the doctor, hey, we're at 25, there's still a lot of leaking. So you'll get a special order because those are rare though. Okay, no matter how big somebody is, we typically don't see, unless they have, because tracheal dilation can occur. Meaning, let's say this patient has been intubated for 10 days. Okay, and then during that 10 days, they've been
They
very,
use-
they've been like tugging at it, say they woke up frequently, very resistant to
So the space becomes
the
like
fentanyl or whatever opioid you're giving, they're very resistant, and then they keep pulling, so it causes dilation,
Mhm.
and then we end up requiring higher inflation pressure. But that's again rare. Okay, there's a important statement here. Routine deflation is not recommended. Okay, we don't do that. Once we set it, that's usually there. All right, unless of course you have signs of aspiration or leaking, which will of course trigger a low pressure alarm on the ventilator. I'll explain that later. Okay, once the patient is on a ventilator, of course, the ventilator will warm and humidify the air, because remember, are we used to breathing through a tube?
No.
No, normally we breathe through the nose, which has hair and moisture, right? So air is warmed and humidified and even filtered by the hair as it enters our airway. This one goes straight from the vent into your lungs. So this one, the air therefore has to be warmed and humidified. The ventilator does that. If the patient stays on the ET tube for longer than 14 to 21 days, now this author says 14 to 21 days. In practice, it's actually 2 weeks, 14 days. We don't go more than 2 weeks because that's really harmful. So if the patient has been on an ET tube for 2 weeks, we switch to a trach the following day. Okay, that facilitates a few things. Once we have a tracheostomy, then we don't need to sedate this patient. Okay, no more sedation. And no more sedation means, can they talk?
No.
Well,
yes, they
well,
can.
yeah.
What I mean by talk, not really talk, but I mean communicate,
don't have any
yeah,
stuff
because,
in there.
I mean, no, they can, they're awake, right? Because
Yeah.
you take them off sedation. So they can talk and they can, communicate with you. They can tell you what's wrong. And can they eat? Yes, they can swallow now. Okay, so you give them feeds. Can they get out of bed now?
Yeah.
Yes, they can sit in a chair still on a bed, but it promotes, mobility. Okay, so they heal faster if you put them on a trach.
How's it
Uh,
gonna eat?
They swallow like you and I. And then
But there is a tube.
no,
separate
tracheostomy already. Yeah, when you have a tracheostomy. All right. So here are the obvious reasons. Okay, so just read them again. It's harmful to have a ET tube. Okay, so trach, if you have to have an airway, trach is the best way to go. Okay, so you read this whole paragraph. All right. Okay, and then here's the tracheostomy. So this is now a different airway. So instead of through the mouth, then it's now through the neck. Okay. All right. Chart 19-12, these are your, this was again later, when we inserted the tube. So I already described the other ways to check placement. So chest expansion, lung sounds, and the end-tidal CO2. But the perfect would be X-ray confirmation. All right, I know we check cuff pressure every 6 to 8 hours just to make sure it's not leaking, because these things can have holes or rupture. Check for aspiration, humidity, oxygen concentration. Now, for oxygen concentration, please always try to go low. All right, never give someone 100%. Okay, if they're on 100%, let's say you started the shift 100%. If it's been an hour and then nobody made any changes, because you can't be in that room forever, right? I mean, you go in and out. And you expect the respiratory therapist, you assume a respiratory therapist must have increased it. But an hour later, okay, they're still 100%. Call somebody, right? That's not right. Nobody should be on 100% FiO2. That just causes oxygen toxicity. Okay, oxygen is very dangerous, especially if you have a mechanical ventilator.
Just for Trach and mechanical vents.
Yeah, it doesn't matter. Okay, high FiO2, 100%, that's never good. Well, you can't have 100% through nasal canyon. It's impossible because you're breathing room air. Okay, it's only for ventilators. Okay. Okay, and then make sure the ET tube is secured well. All right. We use commercial tube holders now. We don't use tape anymore because tapes get wet and then they loosen and then they don't do their job anymore. Okay, so here, something like that. Okay. Although the more commonly used one is this type. Okay, so this is better. So provides really secure as long as the patient's sedated. Okay, so they can't pull on this thing. They're very good. Okay. Plus you can douse them with whatever liquid, it will never come off. Right? They stay put. Okay. And suction only as needed. Check and reposition the patient every 2 hours. And I know the oral hygiene says here whenever necessary. Our routine is when you're turning the patient every 2, we also suction the mouth and provide oral care every 2 hours. Okay, might as well. It's every 2 because these patients can't close their mouth. There's a tube coming out of the mouth. So if your mouth's always open, yeah, dry, it stinks, right? And then, right, yeah, and other bugs enter there, okay, and have children, okay, they hump all day, and then now you have eggs there, okay, so you need to do oral care every 2 hours. Just quickly with extubation, okay, extubation, that means the patient's better now, right? So they passed. This also means that you've done spontaneous breathing trials already. Okay, so you tried already the necessary exercises that okay, they're ready to be extubated. You tell them last minute, okay, last minute things. Okay, you reinforce. All right, so we're going to take this out now. All right, so what we'll do is deflate the cuff, pull this thing up. But since there are secretions above we call this part, by the way, the subglottal area. There will always be secretions here. This section here, above the cuff, we call this the subglottal area because this is your glottis. So subglottal area will be here, under the glottis. So there will always be secretions here. Now we can't reach that, right? Obviously, because there's a certain ET tube that has a second port here. We call it a high-low evap, but I don't know why we don't use it. Probably expensive. Anyway, we don't use that. So we have secretions here, correct? So when the patient is extubated, we tell them after we pull the tube, we want you to cough like crazy. Okay, cough, 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 because that's to get rid of the secretions, right? When we extubate. So we hyperoxygenate the patient. Okay, here, hyperoxygenate, and then when we take it out, tell the patient, okay, cough, 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 and then we suction as needed. We give oxygen and then just watch how they do afterwards. Here, oxygen, keep NPO only just next few hours and then start to introduce ice chips. So because the gag reflex may have been affected because of the tube. That's about it. Okay, let's go to the mechanical ventilation now. I won't discuss suctioning. You already know the procedure. All right. For mechanical ventilation, this is a positive pressure ventilator, meaning opposite our natural ventilation, which is negative pressure. So our diaphragm normally contracts downward. Air is sucked into the lungs from the atmosphere, And same way, exhalation, the diaphragm contracts up and then pushes the air out also passively. Now, when we're using a machine to do the breathing for us, it will be pushed by a positive pressure. So it will push the breath in. We'll discuss the settings, how and then how often, and we'll describe only three modes, frequently used modes. So therefore, there will be also be the three testable modes of ventilation on the NCLEX. Okay. So forget the negative pressure. We don't have negative pressure ventilators anymore. They're in museums, or maybe a few still have them out there, probably in Manhattan, but most of them are in museums now. Okay, so indications, same indications as we already said earlier about patients who are intubated. Okay, of course, if you're intubated, then you're on a mechanical ventilator. So same thing. Okay. I'll go to the mode. Okay. So there are two main modes, which is either volume mode or pressure mode. For the exam, we'll only discuss two volume modes and then one pressure mode. Okay, because these three are the commonly used modes. When we say non-invasive positive pressure ventilation, this is referring to a BiPAP. Okay. Which, by the way, the ventilator is a complex machine. So it's a computerized, highly sophisticated machine. It is capable of functioning as a BiPAP or even a CPAP. Okay. Meaning on the vent, there is a CPAP or a BiPAP mode. Do you understand? Meaning you don't need a separate machine. Okay. You don't need a separate BiPAP or CPAP machine. The patient's on the vent, you can use that thing. Because CPAP and BiPAP can be used as a weaning mode, and it's preset in the ventilator. All right. Just in case they go bad, then you don't have to keep switching. Same machine.
So if the person is on a ventilator, the person is on a high flow ventilator.
There's no high flow. You mean high flow cannula or something? That's a different machine.
That's all different.
Yeah. Okay. So like I said, there's a volume mode and a pressure mode. Okay, let's start with the first one. Most people who are intubated start with the assist control. Okay, so before I describe this thing, let me describe something that's not here. There's a volume mode known as control mode. Control mode. That mode is only used in the OR. Meaning, when you have surgery, so let's say Soler is undergoing general anesthesia, a major surgery. So let's say he had a thyroidectomy. So we intubated him, put him on a ventilator. So since we don't want him moving, so we gave him a muscle paralyzer, opioids, okay, and a sedative, and the general anesthesia. So he's totally out. He's not able to breathe because he's paralyzed, okay, because we don't want him moving. So he's paralyzed, including his diaphragm, so he's on a ventilator. So the ventilator is in charge of everything. So that's why we call it control mode, meaning who's in charge? The ventilator. So the patient in that mode has no say or participation in his breathing at all. So all ventilation is done by the ventilator. All right, you understand? So the vent will give him a specific tidal volume. Tidal volume is the amount of air he will get. Yeah, it's usually calculated by 6 to 8 mLs per kilogram of air. So he'll get, let's say, 400 ml 12 times a minute. That's it. He can't do anything. So let's say Soler wakes up in that mode. He wants to breathe. He can't. The vent won't give him any breath. The vent will say, I'll give you breath when I'm damn good and ready to give it to you. All right. So will that work on someone who is awake? No, we have to paralyze somebody in order to put them on that control mode. You understand? Okay, so that's why it's not here because this is not operating room. Okay, so control mode is only in the OR. Okay, someone who's getting general anesthesia, major surgery. Okay, so the concept of mechanical ventilator is, of course, it will give a breath, right? Okay, and the decision as to which mode to use is made by the physician based on how much work of breathing do you want the patient to do? Meaning, who does the work of breathing? Is it the patient or is it the ventilator? So in the control mode, who did the work of breathing? Only the vent. Okay. So let's start with the assist control. So the description is on the name, assist and control. So meaning the vent will assist the patient while maintaining a level of control. Okay, that's what it means. So since it's assisting, can the patient breathe?
Yeah.
Yes, they can breathe on their own. So let's the names here are AC or SIMV. Okay. No, sorry. BCAC. Okay, BCAC meaning AC. Another term is CMV. Sorry, CMV and AC are the same. Okay, CMV is continuous mandatory ventilation or assist control. Okay, and then the next one will be SIMV, which is more comfortable. Okay, SIMV is synchronized intermittent mandatory ventilation. And then finally PSV. We will not do a PRV. So only these three, AC, SIMV, and PSV. Okay. I'll explain what these mean, okay, shortly. Okay. So control is mentioned here. Okay, so only you know what this is, right? So control is in the OR only. Okay. Okay, in AC, this is what it does. It's a volume mode. And when it's a volume mode, two things are always preset. I repeat, if it's a volume mode, there are two volume modes here. We have the AC and SIMV. AC and SIMV are volume modes. If it's a volume mode, you always have two things preset. There's a preset tidal volume and a preset rate. Okay, preset tidal volume and preset rate. What are the two things preset? Okay, so tidal volume is what again? The amount of air delivered with each breath. Okay, so the calculation is usually 6 to 8 mLs per kilogram. Respiration is the respiratory rate. Okay, how many breaths will the ventilator give? You understand so far? Okay, so this is a shared work of breathing, right? So the ventilator and the patient will share the work. Okay. All right, so let's look at the next statement. However, if the patient initiates a breath between the machine's breaths, the ventilator delivers the preset tidal volume. Okay, so what does that mean? So let's say, okay, so you see the letter B. This one here, not very clear, yeah? Okay, let me just draw it instead. Okay. Let's say this is 0 pressure. Okay, that line is 0. What are the two things preset?
The tidal volume.
Okay, so let's say the the preset tidal volume is 400 ml of air, and the preset rate is 12. So like clockwork, if the vent will give 12 breaths per minute, so that means every how many seconds will the vent deliver a breath? Every 5 seconds. Okay, so let's say this is the first breath, and it's positive, right? Because this is a ventilator, so it's a positive pressure ventilator. So it's always start above 0. So it will go psst, and then it will go psst. Okay. Now the pressure, we call this end expiratory volume. Okay, the pressure will never go to 0 because we put another setting on the vent, which is PEEP. PEEP, P-E-E-P. That stands for positive end pressure. No,
Positive and
expiratory pressure. Okay, positive end expiratory pressure. Now, PEEP prevents the lungs from collapsing. Okay, so meaning instead of going to 0, it will be usual setting is 5. The patient is stable, it's at 5. Maybe initially it'll be at 10. Okay, so it may be 10 centimeters of water, but if the patient is stable, we usually keep it at 5. So let's say this patient is unstable. So Larry was just intubated a couple hours ago. So right now he's at 10. Okay, so his PEEP is 10. So let's say 5 seconds later, the vent will give another breath, right? It's 5 seconds, it's time. Okay, so let's say here on the next one, so Lev decides, oh, I want to breathe too. Now, there's a trigger or sensitivity that is also set on the pump. The trigger is usually a negative number, okay? Because when you breathe, what's the pressure? It's negative, right? So because your diaphragm is contracting, so the ventilator senses that negative pressure, and that's the trigger, meaning, oh, the patient, remember, what does it say here? The patient, when the however statement, where's the, okay. So when the however statement here, it says, where's the however? However.
However, patient ventilated is evidenced by the patient fighting the ventilator above him. That's right.
Okay, right. However,
Oh.
if the patient initiates a breath between the ventilator's breaths, the ventilator will deliver the preset tidal volume. Okay, so back here, if Solev takes a breath, which is negative, correct? So it will dip down slightly. Okay, and then the vent senses that, ooh, negative pressure. That's my trigger. Because the vent has to know when to give the breath. So this is the trigger. Oops, you want to take a breath, eh? Here you go. Psh. He gets the same 400 ml. Okay. Exhalation, by the way, is not going to be the machine sucking anything. Okay. The ventilator will simply stop delivering a breath. The patient will exhale by themselves. Okay. That's how exhalation works. You understand so far? Okay. And then the next breath, when it's time, okay, the vent will give another one. So therefore, will this work if the patient is weak? Yes. He's not able to breathe on his own totally, okay? He needs help. That's why he stays on assist control. So this will go on for several hours, few days, okay? However, once Solev gets better and better and takes more and more breaths, look at what happens. So let's say Solev takes a breath here. What will the vent do again? Give the preset tidal volume. He cannot determine his own tidal volume because that's in AC mode. What will the vent do? However, if the patient takes a breath, initiates a breath between vent breaths, he will get the preset, whatever's preset. He will get 400. The problem here is, let's say, because he's having more and more breaths, so let's say he takes 12 of his own plus 12 from the vent. How much is the total minute ventilation?
Oh, 24.
24 is the respiratory rate. Then he takes 14, 16. So what will happen? Minute by minute. What do you call that condition? Respiratory hyperventilation. Okay, so which will result in what ABG problem? Respiratory alkalosis. Okay, he will go into alkalosis, right? Because he's now taking more breaths per minute. Now, plus another problem with that is, so let's say he just had a breath here. Okay, or let's say the vent gave him a breath, and then he decides halfway through the exhalation, he wants to trigger a breath like this. So the vent will give him another psh. So that will result in a breath stacked on another breath. Okay, so how will he feel? It is like this. Look at this. Okay, because I'm getting 400. So let's say I exhaled 100 and I got 400 again. So that's 500. Okay, so you keep saying, what the fuck is this, right? You say something like that. So he will be very uncomfortable. So this will start getting very, because it's not appropriate for him anymore. It was when he was still doing bad, right? But he's getting better. So can he stay on this? No. So you as the nurse, of course, you're the one drawing the ABGs. Okay, you're not sticking the artery because this patient will have an arterial line. So arterial line, you draw blood, arterial blood, send ABG, and then you see, oh, you observe patient's not comfortable. Okay, so Lev's not doing well. So I'll send the ABG, shows, oh, respiratory alkalosis. You tell the doctor, we'll switch. Okay, so we'll switch him to the next mode, which is SIMV. So same thing, pressure, zero pressure. Okay, so let's see now what happens in SIMV.
And they assisted ventilation with that scenario that you're saying, it's like they're drowning, right?
As they get better, yes, this will not be appropriate for a patient who's doing better. We have to graduate them to the next one. Okay, so SIMV now. Right here. You can skip this one. It's not really common. So AC and then SIMV. It's still a volume mode. So volume modes always have what preset again? Volume and rate. Very good. Okay. The difference here is, look at the next statement. Between ventilator-delivered breaths, the patient can breathe spontaneously with no assistance from the vent. Absolutely no assistance. So what will the vent do when he initiates his own breath? Nothing. Okay, so this is what it will look like. So on SIMV, so Lev gets a breath from the vent. He takes his own breath. Vent will do nothing. He takes 600 tidal volume, no problem. Vent gives a breath. He takes another breath, this time only 200, no problem. It's his breath, the vent will leave him alone. You understand? Whenever it's the patient's breath, vent will not do anything, right? It's your breath, have at it, okay? It's okay, you whatever you want, okay? You're the boss. But if it's a vent breath, vent has to, yeah, right, deliver what is preset, okay? So this is, and another thing here is, it doesn't really, well, in the first place, when we put Solev on this mode, we will drop the respiratory rate. Makes sense, right? I mean, he's breathing more. So we usually drop this around 10, okay? Now, unlike AC, it's usually 14, 12. This one, minimum 10. Okay, we can't give him 12 because we know he's breathing 12 or more. We start at 10. Few hours later, oh, he's doing even better. Drop it to 8. Okay, so the more breaths he's taking, we keep dropping the SIMV. When if that's what we're doing, then we are actually weaning him off, right? Meaning we're using the SIMV. This can be used as a main vent mode, but it can also be used for weaning. Okay, so that's the nice thing about SIMB, because you're not only giving him this as the vent mode, but you're weaning at the same time
Oh.
by dropping the respiratory rate. For the last one, which is pressure, this one's easy. So this is a pressure mode. Pressure mode, so therefore, is there a preset tidal volume? No, because it's pressure. Is there a preset rate? No. The only thing preset here is pressure. So since it's only giving pressure, that's why we call it pressure support. Does it give any breaths at all? No, because there's no rate. There's no tidal volume preset. So all it's programmed to do is give pressure support, meaning the patient has to be breathing on this mode. You can't put a bad patient on this. Okay, the patient must be stable. So therefore, what is this exclusively used for? Only for weaning. This is a weaning mode, purely weaning mode. So the patient is breathing on their own, normal rate, normal tidal volume, or maybe this could be also applicable to someone with low tidal volume, because all the vent is doing is pressure, right? Meaning, think of it as a spotter at the gym. Okay, so I go to the gym twice a day. So I have a spotter there. So when I do my bench press, okay, so sometimes I'm on 250, 300. Okay, so the spotter helps me out.
Yeah.
Okay, so think of it as like a spotter. All right. So Lev is breathing, but not ready to be extubated yet. Okay, so we just need a little more support. Okay, until his diaphragm is strong enough to breathe on his own. Okay, pretty simple, yeah.
You skipped, well, sorry, didn't speak on, the IMP.
No, that's not common.
Only doing three.
Yeah, it's not a common mode.
That's
Yeah, AC, SIMV, and PSV. That's it. Okay, a few things left, which are complications now. Okay, let's go to the okay, settings. We should have started with this earlier, but it's pretty simple. 19-15. You know the tidal volume, yeah? Okay, so 6 to 10, or sometimes it's 6 to 8. Actually don't agree with weight. For me, it really should be the height. Some hospitals use height as the formula to calculate tidal volume, because don't tell me that if I'm 5'4", 600 pounds, that my lungs are that big, right? No, it's mostly fat. But what if I'm 6'5", still 600 pounds, but my lungs would be bigger, correct? Yeah, so for me, it's really the height. But what do I know? Okay. No, most hospitals use only one formula, which is weight. Majority of them use weight. Okay. Again, use the lowest FiO2. Okay, so if you can, patients okay at 40%, leave them at 40%. Okay, don't put them on high because you'll cause absorption atelectasis, meaning you cause lung collapse. Okay, if you have really high FiO2, meaning high oxygen concentration. Okay, again, sensitivity is negative. Okay, so here negative, -2. Usually we use, if the patient's really weak, we set it at -0.5. Okay, that should be achievable by any weak patient. But if they're strong, we set it at around -2 millimeters of mercury. And then you do ABGs, because remember, these patients are intubated, sedated, so they can't tell you anything. So always look at behavior. All right, they're having any. If you have doubts, then draw ABG to be sure. Let's go to complications now. And that'll be it. Okay. Table 19-5. Increase in peak airway pressure. Now, the patient usually has a peak inspiratory pressure. What is that? That is a combination of the lung compliance, how dry or how wet is the patient, meaning this is the resistance posed by the lungs on the vent. So they usually have a baseline, okay? So most PIPs would be around 200, 300. So chronic patients on a vent usually are at 400. Okay, especially those with the short necks. How some people have short necks, maybe fat little old ladies, they have a short neck. So they have a higher PIP, around 400. But most people would have between 2 and 300. Okay. So watch that. They have a baseline PIP, and then if they have increases, so that's usually either increased secretions, okay, or a change in the lung compliance, meaning the lungs are getting wet, okay, or they have some disease process, maybe developing pneumonia, something like that. Okay, and that's reportable to the doctor. So here's your interventions if you have increased airway pressure, so suction, okay, or here, condensation. So this condensation fluid from the circuit is, have you seen a ventilator?
Mhm.
If you've not, let's see. Okay, let's look. Okay, here. So this is the circuit. Okay, this is connected. The patient somewhere here. Okay, so this is the vent circuit. So this is going to the vent, and the patient is here. This is the circuit. Now, because what will the ventilator do to the breath again, to the air? It will warm and humidify it, right? Okay. So what will you get when you have warmth and humidity? Moisture. There's a dependent loop here, correct? So of course, where will that moisture collect? Right here, okay, in any dependent area. It won't collect every day, but it will collect over several days, usually around a week. A week later, you'll have enough condensation there, enough to obstruct the circuit. Okay, so what do? You simply disconnect the patient, just takes a couple seconds, disconnect, drain that tube into a cup, and you can drink it, or you would do whatever you want with it. Okay,
That man.
but what you do not do is do not put it back into the humidifier. Do not put it, obviously, do not put it into the patient's airway, right? Because otherwise you cause aspiration. So what do you do with that? Drain it, and again, I won't say anything to anybody. If you drink it, fine. Okay, it's up to you.
Like the soda.
All right.
Oh my God, no, let's don't consider
You
it.
think it's sterile?
There's always a hundred things.
Okay. So I already mentioned, these are the causes. Okay, so either you have secretions or decreased lung compliance, kinks, tubing kink. Okay. All right, decrease in pressure, meaning this will cause a low pressure alarm. So the causes of low pressure alarms are the following. Increase in compliance, there's a leak, either in the circuit or in the cuff. Okay. Or the humidifier is not tight. Okay, it's loose. Okay, so it will trigger a low pressure alarm, and it's easy because it will have different tones. So if you hear it, you can tell, oh, that's a low pressure. Or just go there if you're not familiar. Just go to the vent, look at the screen. Screen says low pressure. Then these are the causes. So what do you do? Here, so you check the system. Okay, so what's loose? Okay, and if not, then it's maybe a cuff problem. So you call the respiratory therapist. Yes.
For those ventilations that have their masks on as receiving now.
The
that
BiPAP.
are intubated.
No, that's not a vent. That's a BiPAP. Okay. Here, vascular compromise. Now, oh, I forgot to mention. When we intubate a patient, 8 out of 10 of those patients will develop what's called post-intubation hypotension. Okay, that's a natural occurrence. Why? When we intubate somebody and change them from negative pressure a few minutes ago to now 2 minutes later or a few seconds later, they're in a positive pressure ventilation. Can the heart make the necessary adjustment? Because now, is it easy or hard to pump blood to the lungs?
It's hard.
Hard because the pressure is higher now, right? Right? You have now a machine pushing
Mhm.
positive pressure air there, so it will take time. So the heart kind of got a little surprised. Okay, so that will cause hypotension. So in that case, then you'll have to run vasopressor. Okay, so prepare for these problems. So after intubation, they were fine. The blood pressure was fine before intubation. Now suddenly, oh, it's tanking, 60 systolic, 50 systolic. Okay, so just prepare for that to happen. But you have doctors there, don't worry, they'll order vasopressor. Okay, so just make sure your patient has IV access. Okay, because that can happen. And it will take probably 24 to 36 hours for the heart to snap out of it, okay, to adjust, meaning unless they have heart problems, then it's impossible. Okay, so we can stop right here. So somebody remind me. So anyway, the